Our next presentation or session is going to focus on optimizing pre and postpartum care. We have two presentations and 3 guest speakers. First, we have Bree Anderson. Bree is a CDC field epidemiologist assigned to Arizona Department of Health Services. She has worked in the field of sexually transmitted infection epidemiology for 5 years. In her current position, Bree has worked to expand surveillance of syphilis-exposed infants in Arizona and serves as an area manager for many tribal and local health departments. The second presenter will be Danielle Brownrigg. Danielle is a senior disease intervention specialist at the Arizona Department of Health Services and has 12 years experience in healthcare and public health. She has experience working with individuals diagnosed with HIV and spent the last year and a half specializing in maternal and congenital syphilis investigation. Bree and Danielle's presentation is titled Maternal Congenital Syphilis Screening and Treatment. After that presentation, we will hear from Dr. Thompson. Dr. Thompson will present on the ideals and realities of postpartum care. Dr. Thompson received her undergraduate degree in biology from Vassar College and a master's in public health from the University of California at Berkeley. She went on to medical training at Mount Sinai School of Medicine in New York City and recently completed her postgraduate training in obstetrics and gynecology at the Harvard-affiliated Integrated Brigham and Women's and Massachusetts General Hospital Residency Program. She owns and directs Central Phoenix Obstetrics and Gynecology in Phoenix, where she is also a clinical assistant professor in the Department of Obstetrics and Gynecology at the University of Arizona School of Medicine, Phoenix, and an adjunct professor at Grand Canyon University and the Arizona State University College of Nursing and Innovation. Dr. Thompson is passionate about helping women of all ages to make empowering life choices. She is the author of Your Ideal Life Now. So now we'll turn it over to Bree and Danielle. Thank you.
All right. Good morning, everyone. My name is Danielle Brownrigg, and I'm a Senior Disease Intervention Specialist with the STI Control Program here at ADHS.
My name is Bree Anderson. I am a CDC field assignee epidemiologist assigned to Arizona Department of Health Services, and we are here to talk to you today about congenital syphilis in Arizona. This presentation is going to provide a brief clinical overview of syphilis and congenital syphilis. We're going to examine current epidemiological trends and changes over the last few years, opportunities for congenital syphilis prevention. In 2018, Arizona started monitoring all infants that were exposed to syphilis in an effort to determine the differences between syphilis-exposed infants and those that we were able to prevent from becoming a syphilis case. And those that resulted in a congenital syphilis outcome. So basically in 2017, 2018, instead of just tracking just those that became a congenital syphilis case, we also started tracking the ones we were able to prevent from becoming a congenital syphilis case. For this presentation, I've included 4 years of data, 2018 to 2021. Disclosures, we do not have any conflicts of interest to disclose. Before we get started, I want to cover a couple of terms that I'm going to use throughout this presentation. A syphilis-exposed infant is an infant that is born to an individual who has untreated or undertreated syphilis at any point during pregnancy. A prevented congenital syphilis case is an infant that is born to an individual who had untreated or undertreated syphilis at any point during pregnancy, but the mother received appropriate treatment 30 days or more prior to delivery, and the infant had no signs or symptoms. And finally, a congenital syphilis case is an infant who was born to an individual who had untreated or undertreated syphilis at the conclusion of their pregnancy, which is regardless of the symptoms in the infant, or the infant had at least one symptom of congenital syphilis and a reactive RPR. During this presentation, I'm going to occasionally use terms such as male or female. I've tried to avoid using these terms where possible, but we have limited data on gender identity in our data set, and these terms will likely correlate with sex at birth. Before we can talk about congenital syphilis, we have to briefly cover syphilis manifestations in adults. So what is syphilis? Syphilis is pretty complicated, but very briefly, syphilis is a treatable bacterial infection that is spread when an individual comes into contact with an infectious sore or lesion. This is typically through sexual contact, but it can be spread non-sexually. It's often called the great imitator because its symptoms can mimic many other diseases. Following the initial incubation period, the case experiences 2 symptomatic infectious periods. These infectious periods can last anywhere from 1 week to just under 2 months. Although the case is symptomatic, it's super easy for these symptoms to go unnoticed. This is particularly true for persons in the primary stage because their symptoms are most often painless and appear at the site of infection, which may be a non-visible location. The symptoms of secondary are a little bit more obvious, but it's super easy to overlook these symptoms or mistake them for something else. Although most cases only go through 2 infectious periods within the first year of infection, some do relapse into a secondary stage, and this relapse can occur at any time. The first 12 months of infection we commonly refer to as new syphilis. Understanding the distinction between new syphilis and later unknown duration syphilis is important given that treatment changes based on the stage of infection. Historically, syphilis has predominantly impacted men who have sex with men, or MSM. And in Arizona, we saw about 1 in 5 cases occurring in females. But in recent years, this has started to shift rapidly, and syphilis in women has increased 449% since 2015. This is particularly concerning given that the pregnant persons can pass their syphilis infection to their unborn baby. While most adult syphilis cases only go through 2 infectious periods, untreated pregnant persons can spread the disease through the placenta to the unborn infant, and this transmission can occur at any stage of syphilis and during any stage of pregnancy. However, we do see much higher rates of transmission and nastier outcomes within the first year of maternal infection. Meaning if the mom had untreated new syphilis during her pregnancy, then the baby is at an increased risk of dying or being symptomatic at birth. The good news is that congenital syphilis is preventable with appropriate screening and treatment of pregnant persons. If they initiate appropriate treatment 30 days or more prior to delivery, congenital syphilis is usually prevented. So what happens if syphilis does spread to the baby, and what is congenital syphilis? It's a severe, disabling, and often life-threatening infection that's seen in infants. It can cause fetal demise or death shortly after birth. Syphilis can cause issues with the eyes, brain, ears, teeth, heart, skin, and bones. Syphilis can often cause preterm delivery, further complicating the need to initiate maternal treatment early. I'm going to skip this slide and talk about it on the next slide, which I have updated numbers on. Unfortunately, as many women only get tested for syphilis during their pregnancy, the rise in babies is mirroring the rise in women. And these numbers just keep going up. Prior to 2017, Arizona had about 14 congenital syphilis cases each year. In 2017, that number doubled and continued to double every year for the next couple of years. We now average well over 100 cases a year. In 2021, we had 181 congenital syphilis cases, 14 of which were stillborn or died shortly after birth. If you recall, 14 used to be the total number of congenital syphilis cases across the entire state. And now we exceed that number in stillbirths and infant deaths alone. We recently finished closing out 2022 data, and we ended the year with 219 congenital syphilis cases, which includes 26 stillbirths and 7 infant deaths. Unfortunately, as many women only get tested for syphilis during their pregnancy, the rise in babies is mirroring the rise in women, and the numbers just keep going up. Prior to 2017, Arizona had about 14 congenital syphilis cases each year. In 2017, that number doubled and continued to double every year for the next couple of years. We now average well over 100 cases a year. In 2021, we had 181 congenital syphilis cases, 14 of which were stillborn or died shortly after birth. If you recall, 14 used to be the total number of congenital syphilis cases across the entire state, and now we exceed that number in stillbirths or infant deaths alone. We recently finished closing 2022 data. We ended the year with 219 congenital syphilis cases, including 26 stillbirths and 7 infant deaths. Additionally, the cases are spread across the state. Pre-2016, almost all cases were in Maricopa or Pima counties. It's now affecting almost all counties in Arizona. And if a county didn't have a case last year, they will likely have one the following year. While syphilis used to be more common among those who were assigned male at birth, it is shifting faster to persons with childbearing capacity in these rural areas. Additionally, individuals living in rural areas do not have the same options for prenatal care that those in urban areas have. They may have to drive further distances or have fewer options. Arizona also has a much higher rate of congenital syphilis than the US average. In 2021, we had 236 cases per 100,000 live births, while the US averaged 74 cases per 100,000 live births. Additionally, state rankings in Arizona, or state rankings had Arizona as #1 for the highest rate of congenital syphilis in 2021. The best news that I can offer is that congenital syphilis is very treatable. Many of the sequelae associated with it are reversible with proper treatment. The unfortunate reality is that not all infants in our state receive treatment according to the CDC and Red Book guidelines, or they don't receive any treatment at all. Despite efforts of public health, 5% of our congenital syphilis cases are not being treated. Additionally, 10% of congenital syphilis cases are receiving some form of treatment, but not the recommended treatment according to the STD treatment guidelines. You see, the complexities of these cases do not always end at delivery. These numbers would both be much higher if not for the interventions of public health. About 13% of congenital syphilis babies were adopted into other families. These adoptions often do not come with the information that the person who gave birth to them was infected with syphilis. Providers have a big role in ensuring infants receive appropriate follow-up. This is less of a clinical presentation on congenital syphilis. I'm not really going to go into the testing and treatment. Please refer to the Red Book guidelines for appropriate testing and treatment. I will say this: if you are a provider and you have someone who has just given birth with a reactive syphilis test, call your local health department to get a history. Do not rely solely on the information that is provided by the patient. They may have been reinfected or inadequately treated in the first place. After contacting your local health department, use the information provided in the Red Book to determine proper evaluation and treatment. The local health department will also be able to help you determine appropriate testing and treatment for the infant, or you are also always welcome to call us. You might be wondering what the role of public health is in these scenarios. Our role has greatly expanded over the last few years, and it is constantly changing. GIS, of course, are following up with individuals who have positive test results, getting them treated and connecting their partners to preventative treatment. We have built codes that cross-match those of childbearing age with birth and fetal death records. We are constantly looking for misidentified pregnancy status or information on the infant. We review any cases that we know to be pregnant to determine an outcome for the baby. Often when we give a presentation on congenital syphilis, I like to tell stories about specific cases that have been prevented. We're a little short on time today, so I'll just say this. Our combined efforts have prevented 461 cases of congenital syphilis from 2018 to 2021. Depending on the year, we prevent roughly half of the infants that are exposed to syphilis from becoming a congenital syphilis case. It's very easy for me to get hung up on this number, roughly half. I always feel like we should be able to do better than just 50%. These are often very complicated cases that are hard to reach. We have so many factors working against us, but despite that, in just 4 years, this has added up to 461 prevented cases. which is not a small number. I've mentioned that these cases are very hard to reach and that these are often very complicated cases. So what are the gaps in being able to prevent more congenital syphilis cases? The biggest cause in cases of congenital syphilis is inadequate or no access to prenatal care. This is where the majority of our cases fall off from being able to be prevented. 35% of our congenital syphilis cases end up being cases due to no prenatal care, or they initiated prenatal care less than 45 days prior to delivery. The number of cases due to no prenatal care was not always so high, and it's actually currently even higher than that. As you can imagine or have heard, the COVID-19 pandemic dramatically altered the delivery and access to healthcare across the United States. We likely won't know the true magnitude and results of this change for many additional years. Healthcare visits in outpatient settings were down by 60% in March and April of 2020, which would include prenatal care appointments. Additionally, many healthcare workers were furloughed, laid off, or had work hours cut due to low non-COVID patient volume. Some of these jobs may not be restaffed as things begin to return to normal. Some healthcare workers may not return to the workforce, or they may return in different roles. Those who had syphilis during pregnancy may have been impacted by these changes in healthcare access, as we saw dramatic shifts in prenatal care access during this time frame. Of those who gave birth to a congenital syphilis baby, 26% of them had late or no prenatal care pre-2020, compared to a whopping 40% in 2020 and 2021. There are many other factors that may have been caused by the pandemic that may also be contributing to these increases. While methamphetamine use has been long linked to congenital syphilis in Arizona, during this pandemic timeframe, we saw a surge in reports of opioid use, specifically fentanyl. Opioid use among those who gave birth to a congenital syphilis baby increased by 200% within this timeframe. It is not known how much opioid use has increased in the general population, but there was also an increase in opioid-related deaths in 2020 to 2021. So let's talk about this prenatal care issue and how we might be able to find some of these cases. When we talk about some of the more powerful modifications we can make, testing pregnant women who are not accessing prenatal care but are accessing emergency services would be one of the more impactful changes that we could make within our state. We know that 35% of those with no prenatal care had at least one emergency room visit during pregnancy, and many of them had more than one. Due to issues with treatment that I will discuss in a few slides, it may be advantageous to use rapid syphilis tests in this setting to provide treatment based on the rapid test results. If we look at other touch points to care, we did see a small number of cases that were seen in methadone clinics, rehab facilities, STD clinics, urgent cares, and jails. We've talked about the issue of no prenatal care, but what about all of these cases who do report having prenatal care? How are so many of them resulting in congenital syphilis outcomes? The next area that we're working on targeting is providers who do not routinely test 3 times during pregnancy. This is a smaller issue than some of the others might be, but it's also one of the ones that might be the easiest one to remedy. I'm going to cut this slide a little bit short as we're short on time, but basically in Arizona, we do require screening 3 times for syphilis during pregnancy, once at the first prenatal visit, once early at the 3rd trimester, and once at delivery. We are one of very few states that require it 3 times during pregnancy. The issues with testing has accounted for 8% of our total congenital syphilis from 2018 to 2021. And during this time frame, that has not been a small or insignificant number. That's 38 congenital syphilis cases were caused by them being in prenatal care, but not being tested for syphilis at their prenatal care appointments. A lot of these cases are a result of inconsistent prenatal care and potentially off-site labs. It's important to note that the recommendation and the law is to screen at the first prenatal visit. And what we found is that a lot of providers will have what I like to call a fluffy first prenatal visit. It's a meet and greet with the provider, and they do not always draw labs. Or maybe the provider will refer to an off-site lab. This might be the only touch point to care that these pregnant persons have, or they may not have another prenatal visit until it's too late in the pregnancy to prevent congenital syphilis. Please do not wait to draw these labs and complete them in-house if possible. We also see a fair number of labs that are ordered, but because they require a trip to another facility, they don't get the testing done. The next area that we're working on targeting is a little bit more complex. Issues for treatment account for 19% of our congenital syphilis cases. This issue is very broad. It includes a variety of treatment issues, including those who maybe are undertreated or don't get their treatment spaced appropriately. Bicillin, which some of you may have heard is in shortage currently, is the only recommended therapy for syphilis treatment. Unfortunately, it's very pricey, hard to store, and not really used for anything except for syphilis treatment. Because it's not routinely used, most providers and pharmacies don't stock it. Instead, they refer patients to the county clinic, which is great, except that the county clinics may require patients to travel further to get to the location, and the business hours may be limited. And also, as I mentioned, it's currently in shortage, which is just great. We are having some, and by great, that's a very sarcastic great, we're having some counties that are reporting that they do not currently have enough to treat just their pregnant patients for the next 90 days. As a state agency, we are working to get them those doses available. I will say that bicillin is the only acceptable treatment for pregnant women, but you can use doxycycline for non-pregnant patients. It's just a longer duration of treatment, and we do have some concerns that people might not finish their doses. The next category to discuss is the vast number of new syphilis cases that we have in the state. We have seen massive increases in syphilis infections that have been acquired within the past year. This is playing a big role in the number of congenital syphilis cases that we have in Arizona. 22% of those who gave birth to a congenital syphilis baby acquired the infection during pregnancy or were reinfected with syphilis prior to delivery. This is accounted for 102 cases from 2018 to 2021. Usually when I give this presentation, I like to have a full hour to discuss this topic, and this might seem like an abrupt wrap up to the presentation as we are very limited on time. The categories that I've outlined highlight the extensive disease transmission that we have in Arizona and the importance of the work of public health and providers. It's easy to look at the rising case counts and wonder what is going wrong. Congenital syphilis can take up to 40 years to show devastating symptoms, so the fact that we are finding these cases now and linking them to services is a success. The issues that I've discussed here today are not going to be solved in a day, and they're not going to be solved by one person. It's going to take all of us working together to decrease the number of congenital syphilis cases within our community. We literally cannot do it without you. I'm now going to pass it to Danielle, and she's going to share some of the resources and projects that we currently have available.
Thank you, Bree. I'm just going to turn my video off because it keeps freezing. So please let me know if you can't hear me. Now I'd like to share a few projects and resources that you can use to help prevent congenital syphilis. The first is this Protect Your Baby pamphlet. This is a two-sided brochure that provides a very quick overview of the possible signs and symptoms of syphilis in the pregnant person and the baby. It also lists the 3 required testing points in pregnancy and the phone number to all of the health department clinics in the state. This brochure is provided in both English and Spanish. This resource is a chart adapted from the Red Book, and it helps the reader determine which congenital syphilis category that the baby falls into. Not pictured is the reverse side of the chart, which has the testing and treatment recommendations for each category. At the end of the presentation, we'll have a QR code if you would like a copy of either of these handouts. The Catalyzing Congenital Syphilis Prevention Project is a partnership between Maricopa County Department of Public Health and the local healthcare community organizations designed to deliver syphilis screening and treatment services to pregnant persons and people assigned female at birth who are of reproductive age in an effort to promote STI awareness, increase syphilis testing, and prevent congenital syphilis. The project began as a referral-based process where the Maricopa County Public Health Department provided at-home comprehensive STI testing services to clients free of charge including syphilis, chlamydia, gonorrhea, and HIV testing. The project linked clients to the Maricopa County STI clinic if treatment was required. To enhance the knowledge and awareness surrounding STIs, safe pregnancy, and sex education, the project also delivered educational training to participating sites and their clients. In response to partner needs with the aim of boosting STI testing rates among participating sites, the project further expanded its scope to include STI outreach events. Ventanilla de Salud, which operates jointly with the Consulate of Mexico, is currently one of the participating programs that is actively making referrals for testing clients and also regularly offers on-site testing through their outreach events. The outreach events started in early 2023, and they occur on the third Tuesday of every month during the mornings. No appointments are needed. Clients just need to arrive before noon. All STI testing is offered on-site at no cost. So anybody can participate in the free testing, but for the project itself, only pregnant people and people assigned female at birth who are of reproductive age will be eligible to enroll in the project. And finally, here's some additional resources. The top two QR codes are through Indian Country Echo. The first QR code is for the Stop Syphilis campaign site, where you can download and order materials, including videos, stickers, billboards, and pocketbooks. The second resource is for the Plans of Safe Care Toolkit, which helps families and providers support pregnant and parenting people with substance use disorder. The third QR code is for the Think Syphilis campaign, and here you can find resources for free and low-cost testing in Maricopa County. And the final QR code is to order materials through EDHS, which include the Protect Your Baby brochure and that Red Book flowchart. Thank you so much for your time. We will have questions at the end of the following presentation.
Thank you. Thank you, Bree and Danielle. That was a wonderful presentation. Our next presenter is Dr. Sharon Thompson. Dr. Thompson, can you come up to the platform? There you are.
Hi, everyone. Thanks for having me. I'm going to go ahead and share my screen, and we'll be talking about postpartum care. So let's see. I hope everyone's seeing my screen right now.
Yes, we can see it.
Excellent. So we're going to talk about ideals and realities of postpartum care. I don't have any conflicts to report today. In terms of learning objectives, I'm hoping that by the end of this presentation, you'll be able to outline some ways that postpartum care can improve maternal health, describe at least 3 barriers to ideal postpartum care, and identify some policy and process changes that would enable us to get to the ideal that we're going to talk about. So as to an agenda, we're going to talk about some of the ideals of postpartum care, some of the challenges of the postpartum period, some of the work that's being done in this area, and then innovations for change. So let's start by talking about the ideal for postpartum care, because we all live in the barriers. This is the system we're living in. So let's talk about where do we want to go. And this slide is pretty busy, but I think it's a good sort of roadmap. If you look at the sort of bottom third of the screen below the timeline that shows the weeks, it shows you what we do now. So women have a traditional period of rest and recuperation. Let's put that in quotes because it might not be so restful for many women, of 0 to 6 weeks. And then there's the traditional 6-week postpartum visit with a provider or clinician. But what the American College of Obstetrics and Gynecology and the expert panel they pulled together has proposed is that we start thinking of the postpartum period not as that single 6-week, okay, you're clear follow-up, but more as a continuum of care. And so that all women would ideally, and now we're moving to the top third of the slide, all women would ideally have some contact with their provider or clinician in the first 3 weeks after having a baby. If you had some blood pressure issues, either during pregnancy or postpartum, you'd be seen in the first 3 to 10 days. If you had some other high-risk condition, you'd be seen in 1 to 3 weeks. And then following that, you would have comprehensive care in the next 4 to 12 weeks as fits your particular context. And so this is sort of where we want to be in terms of a timeline. In addition, if we sort of break this out and look a little bit more at what would that postpartum care include, it starts in the prenatal setting. And that, here we're talking about the ideal. So if you're just jumping out, we're not talking about what we have. We're talking about what we want, what would we think would be better care for the folks we serve. And starting in a prenatal period with some anticipatory guidance about what the postpartum period can be like, what that woman can expect, the changes she can expect in her body, in her sort of sociology, right, her household, now that she has this new person, warning signs to look out for, et cetera. And that we turn postpartum care into an ongoing process rather than a single encounter. In that initial contact in the first 3 weeks, we're going to look at blood pressure issues, any complications during delivery. We're going to hear her about what her experience was. As we know, and I think other presenters have covered in this conference, the labor, delivery, birth, prenatal process can be less than ideal for many women. So sometimes women need to be heard about that experience that they had, and follow that initial contact in the first 3 weeks by a comprehensive physical assessment, sociological assessment, mental health assessment. The next sort of box in this slide goes over what should be in that full physical assessment. I won't read through all of that, but it's very comprehensive, looking at everything from mood, sexuality, birth control, sleep, fatigue, infant feeding, etc. An important note about women with chronic conditions: it's underappreciated that many of the complications that we see in pregnancy have implications for a woman's health going forward. So as she goes on in her life, and to have a place to discuss those and make sure that she's getting appropriate postpartum follow-up and also appropriate referrals to the specialist that she will need for her ongoing wellness and well health. And then to identify not only the specialist that she may need, but who's taking over her care. Is she going from OB care to nothing? Or is she going to an appropriate primary care provider, whether that's family practice or internist, et cetera? So that's a brief and quick overview of the ideal. Let's talk about why we're not there. What gets in our way of doing that? And some of the challenges are cultural. And when I say cultural, I mean America, how we approach labor, delivery, birth, and postpartum. Some of them are medical, how the healthcare system is set up, how doctors and midwives are trained to give care. Some of them are health system issues. How are hospitals and health facilities set up? Some of them are payer issues, health insurance issues. Do women have health insurance coverage after they have the baby? Once that baby's head is out, does her coverage go away, or does she continue to have assistance with paying for her health care? So there's so many factors that factor into the challenges. There are family issues, social stresses. Is she the financial support for her family, and does she have to go back to work? Because as many of you may know, we don't live in a country that has paid family leave. Much is said and heard about the Family Medical Leave Act, FMLA, but many people don't appreciate that that is unpaid leave. What FMLA guarantees is that your employer keeps your job, but it does not guarantee that they pay you for that time. And there are many, many, many women and families in this country that cannot afford for her to be out of work for 6 weeks, 12 weeks, et cetera. So many women have financial pressures to get back to work, even if they have a C-section, even if they have a complicated delivery. And that can complicate her healing and her recovery in the postpartum period. There's social issues related to relationships. We know that pregnancy is a time where partner violence, intimate partner violence can increase. And so now she has to protect herself and a young child, not to mention the ones that she may already have had at home. And because of many of those logistics, as many as 40% of women don't attend a postpartum visit at all. And those logistics and other issues, obviously. And many women report that even when they go for postpartum care, they're not getting what they feel like they need. And the sort of slide that's the box that's highlighted here is policy change. So I mentioned paying for leave for women. That's one of the policy changes we need. There's insurance coverage changes that we need. There are employer changes that we need. One of the things that as more women enter the workforce, we're realizing is the world of work is not designed with women in mind. The world of work is designed for folks who don't have children who are attached to them. And by attached, I mean the people who have primary responsibility for children, whether those children are breastfeeding, whether they're in school, whether they just get sick and need someone to go take care of them. The world of work is not designed for that. Those considerations and responsibilities are seen as disruptions to work rather than work being designed to have those factors integrated. And so that makes it challenging for women who are recovering from having a new baby. So they're just a high level overview of some of the challenges that we see and the reasons why we don't have that ideal that I talked about. So the next slide is simply to make the point. Folks have been thinking about this for a long time. This is just a smattering of some of the publications that look at the postpartum period, whether they're looking at the postpartum from the baby's perspective. And I want to highlight here the 2002 book by Karp, who's a pediatrician, who I think was the one who coined this phrase, the fourth trimester. And many of you now may have heard of that term because it's been taken up in the obstetric world as well, not just to look at it from the baby perspective, but also to look at it from the maternal perspective in terms of her need for recovery and her body transition as she's getting what I call unpregnant. But this slide is to show that there's been a lot of work done in this area. Sometimes as we're addressing problems, we're tempted into the fallacy that we're the first ones to think about this. And people have actually been thinking about this for a long time, including CMS, the Centers for Medicaid and Medicare Services. As early as 2015, they were trying to think about how can we be thoughtful about payment models to incentivize providing the kind of prenatal care that we know women need and we want to give. So the whole point of this slide is just say there's a lot of work done in this area. And so what are some places where people are looking to create solutions and innovations? I think someone mentioned in the earlier slide the CDC campaign called Hear Her. And basically what the CDC is trying to do is to engage the everyone box here to say that all of us have a role in providing sort of a village for women and birthing people who have just recently given birth, because there can be warning signs that we should all know about. Let's say your colleague in the next cubicle over is down and tearful and you hear sniffles from her cubicle every day since she's returned from having her baby. That may be a red flag. Hey, let me ask her, or let me bring this to someone's attention that she may need assistance. She may not be ready. These may be signs of postpartum depression, but we all have a role in knowing what those warning signs are and being mindful that folks who have just given birth are still in need of care. They're still in need of support from all of us. But there are a lot of other stakeholders, right? We're all stakeholders. Employers, I mentioned, in terms of work leave, in terms of giving folks who just had a baby time and space to maybe take additional breaks because they still need that. Maybe pump milk for their babies because they need to do that. Paid leave, wow, that would be awesome. And some employers are doing this. There are employers who are definitely leading the way. Health and hospital systems and birthing facilities can do a lot in terms of preparing women for postpartum discharge from the hospital, connecting them to care providers, making sure that that handoff is one where the receiving care provider understands what has happened during the intrapartum period. Healthcare providers, of course, in terms of connecting with women in that early postpartum period, in terms of making sure that we keep top of mind the things that happened during the pregnancy that now we need to follow up on postpartum. For example, if a woman had gestational diabetes, she needs some testing postpartum to see that the diabetes is now gone. So providers have a role there. Women and birthing individuals, in terms of setting boundaries, because I find that women are socialized, and here I'm particularly using the word women, because women are socialized to take care of others, to nurture. As soon as we're out of the womb, we're given babies to care for. So we tend to put ourselves last and not draw boundaries around our need for rest and recovery and sleep and quiet time. And so the postpartum culture in America is one of visiting. Everyone wants to come and see the baby, but that can be exhausting. for mom and for baby, for the individual who's given birth and the baby. Insurance payers have a role in terms of coverage for everything from breastfeeding support to making sure that postpartum care is covered throughout the postpartum period, paying for services around postpartum depression. Then that includes provider services, clinician services, as well as therapists and psychiatry services. States, tribes, and local communities have a role in terms of setting the stage for folks to have healthy pregnancies. Cities and states determine where are the recreational areas? Where can people go for respite? Are there community centers in your town? These are all things that can be useful to families as they bring that new member, bring that new baby home. Families have a role in terms of, like I mentioned before, care of that pregnant woman, understanding that pregnancy is not ended when the baby's head is out. That woman is still recovering and going through that 4th trimester. And of course, there's lots of research that can be done, both on the physiology of pregnancy and the postpartum. We can think especially around mood disorders. Why do women get postpartum depression? That is not obvious. And we definitely could use more research in that area, as well as how do we manage some of the postpartum complications that women can see? What is the physiology of those, and what are some effective treatments of those? And so to solutions, I mentioned the 4th trimester, and that is the idea that after the baby's head comes out, there's still care that this woman and baby need, and that we should think of that still as a precious time related to this period of gestation. Telehealth has been a big innovation. I mentioned 40% of women don't make it to that postpartum visit. And you can imagine why some of them don't, right? You have a new person, you have maybe your little people you had already, you're managing your own health, how you're feeling, your recovery, your partner, your family. Do you have childcare? So telehealth has really been a big help for some women who can do a phone or a video call, but couldn't make it, couldn't get themselves together to get to the hospital, maybe transportation issues, whatever it is. So that's been a big help. And we hope that that stays around even after the pandemic. Health navigators and doulas can be very helpful as well, because they have a capacity to connect with women, even if the healthcare provider isn't able to do so, or in spaces between those healthcare visits, and provide some assistance and that kind of care I was talking about, provide that there. Some folks and companies are working on health tracking software and different apps that folks can use. Again, these are technologies that can be with that person, that person who's birthed, wherever they are, and perhaps connect them to the clinician that they need if that's the case, or help them identify warning signs or indicators that they might need to seek another level of care. So that's an area where we're seeing innovation. Group models of care can be helpful. We know in the prenatal setting that group prenatal care has been shown to have, in studies, to have lots of benefits for individuals who are pregnant. And in the postpartum period, we're looking at those also. Like I mentioned, CMS is looking at different payment models and how can we incentivize the kind of care that we want women to get, that we want to provide. An expanded maternal health coverage period. Many states are providing this extended coverage period. I know in Arizona, I forget when exactly we did it, but our Medicaid program has extended the postpartum period for a year. And that is more complex than it sounds, because simply extending the amount of time is good, but then we want to make sure that clinicians are understand that is the case, and also that we pair that with the payment models so that we're incentivizing the care that we want women to get. And the last thing, let me go back to that slide, is systems change, right? So there's so many systems and policy changes from laws that prevent discrimination against pregnancy and postpartum women. Back in June, I forget what it was called, but basically it's a new federal law, because there was one before, that again reiterates and has penalties for employers who are not providing the accommodation that pregnant individuals need as they cope with the changes in their bodies or disease states that arise or complications around pregnancy. That's one of the policy changes that we need. There are some other policy changes in the works or coming about doing quality improvement initiatives. There are many that have been done in the hospital setting in terms of reducing maternal mortality and looking at data around how we can best apply our both human and intellectual technology and also sort of computer and app technology to decrease morbidity and mortality. And there are actually some groups that are looking at how can we apply the same sort of thing in the postpartum space, both in the hospital setting and then in the outpatient setting, to decrease. The previous presenters told us half of deaths don't occur in the hospital. They occur in this postpartum period. So how do we put processes and policies and programs in place to make sure that we're bringing the best quality to individuals who birth to protect their health and protect their lives? So these are some of the sort of big buckets of places we can look to for solutions, and that people are working on different solutions. I think that it would be naive to say that we're even close to where we want to be, but we sort of have a roadmap for where we can go. And we definitely have folks working in all these spaces to try to get us there. And of course, community change, right? All of this underlies community change, especially change in our perspective about the needs of the postpartum period, and also our cultural sort of norms and attitudes. And I'll close in a second, but I do want to say one of the places that we can look for wisdom and solutions is actually a place that should have been ours all along if we had not had sort of racism and genocide and xenophobia. And that is to Native American communities and indigenous communities all over the world who traditionally have periods of sequestering a recently birthed individual and her baby, and community care for those individuals and their babies. And through American history, we have sort of thrown those traditions away or thought they were not valuable. And it turns out that some of the solutions to the problems that we find ourselves in today lie in those traditions that we thought were not valuable. So I just want to make sure and point out that we don't have to create things all anew to find solutions to our problems, but sometimes it requires looking at places and cultures and traditions that are among us now that we have previously not appreciated. And so I will stop talking there. The remaining slides are just lots of references for you, and take your questions and comments.
Thank you. Thank you so much for your presentation. Really appreciate your perspective and the big buckets that you really organized so nicely and easy to follow. So we do have a couple of questions that came into the chat, and I'd like to, Dr. Thompson, since you're on the screen right now, one of the questions that came in is, how can students in medicine and allied health professions help mitigate the high maternal mortality rate in Arizona? And that is from Fetal.
So maternal mortality is a complex issue in that there are lots of factors that go into affecting a woman's health in pregnancy. Some of those factors are physical, right? Related to things like hypertension and hemorrhage and heart disease in pregnancy that can affect a woman's mortality. Some of the issues have to do with the quality of care and attention that woman gets. And this is areas where we see bias and racism fitting in. So when a person shows up for care, whose complaints are listened to, whose complaints are taken seriously. And we know that African-American women, Native American folks have a higher mortality rate and also experience more bias in the healthcare system. So that's another factor. Another factor that plays into maternal mortality, as we heard in the previous presentation, has to do with substance use. And the fact that we as a culture have denied substance use as a medical issue, we don't have enough treatment for it. We've seen it as a criminal justice issue instead of as the health issue that it is. And that factors in too, to a lot of the issues that result in maternal mortality. So it's a multifactorial area. So what can students do? You can get involved in any of those areas. So being a great clinician who pays attention to issues of bias, issues of substance use, that will put you head and shoulders above what we're doing now. So just as people often feel like they have to do something else in addition to their training. No, being a great clinician, we need you to do that, right? Being someone who understands the importance of mental health and the role or the changes that happen to mental health in the pregnancy and the postpartum period. Those things alone will improve our system. So I think sometimes students think of what else, but what you're doing is a lot. And talking to your family. Remember I said there's a role for family members, there's a role for the whole community. Your family members are voters. Make sure they vote. Talk to them about the issues that are important to you so that we can start building communities that are supportive to folks who are pregnant and folks who are postpartum. But just doing your clinical training is a lot, and we'll take that.
Thank you. This next question is for Bree. One of the questions that came in, Bree, while you were presenting and mentioned stillbirths, the question that came in said, that sounds like a high rate of stillbirth. Is that a common outcome of exposure to syphilis in utero? And that's from Karen Kelsch.
Yes, it is it's a relatively common outcome. So the other important distinction that we should make with this is we only count stillbirths if they make it to 20 weeks gestation, or if the fetus weighs 500 grams. So we're missing a ton of cases that are less than 20 weeks or way less than that. So that's like a known thing that we've kind of started to track, but there's not really like any databases that allow us to like really match into those databases to like really adequately count those. So the other interesting thing that I'd like to point out, 2022 was kind of a shocking year. The stillbirth was probably not that abnormal, like the 10 to 15% is pretty standard, but we did have 7 infant deaths, which is way higher than it has been in prior years. That's kind of an outrageously high number. Also during the pandemic years, we seem to be missing, like that rate seems to be lower, but I would guess that that's an artifact of like us missing cases more than it is that they're not there.
And Bree, while you're on the screen, I just, and I know you answered this question, but I do think it's important for everyone to hear this. One of the questions that came in from Andrea Gallegos, her question read, you said it's required to test syphilis 3 times during prenatal care. Has Arizona put out a public health order to mandate this? And if you could please just share your response to the audience here.
Yeah, for sure. And I wanted to make sure that I had those numbers, which is why I put it in the chat. So it's actually split into 2 places. So the first prenatal visit and delivery testing are required according to ARS, which is the Arizona Revised Statutes. And then we got an update for the Arizona, what does that stand for again? I'm blanking for a second. Arizona Administrative Code.
So it's
is
in
what was
rule.
updated. Yeah, 3rd trimester testing.
Okay, thank you. And you did include that in the chat. Really appreciate that so people can have access to it. And we'll make sure when we summarize the document, we'll put the links into both the statute and the administrative rules so people can have that. Let's see if we have another question here. I think we have just some comments that came in. One question was whether or not, again, Bree, have traveling van clinics are traveling van clinics being considered? That was from Roberta Ward. And then we do see a response from Laura Moore, responded that this is in the works. Is there anything you want to add to that, Bree?
For the traveling, I can't really speak to traveling vans. Some of our local partners might have that available specifically for screening. What will happen at a lot of those departments is they will provide treatment services in the field if they are able to locate the patient. So that's a very common thing that we keep having pop up, is that, you know, some of these women or, you know, persons that are pregnant even do get screened in the emergency department setting, but then they're discharged and they're just borderline impossible to find. We're talking, a lot of them report homelessness, like it's probably in the 10 to 15% range. But more common than that, we have unstable housing. So these are people that are staying with friends and family. They don't have a consistent address, which makes it really hard for us to find them, to get them connected to treatment. So there is some services that are provided by the local health departments where they'll go out and do field treatment, but it's contingent on them knowing where that person is or being able to locate them.
Okay, thank you. And Dr. Thompson, this will be our final question before we go into our lunch break. I see one that came in here from Isabel Fagman. She states, first of all, Dr. Thompson, that was very encouraging. Thank you. What are we doing by just, I'm sorry that my chat is jumping around for me. What are we doing by just paying attention is important. I'm very interested in studying mental health in the criminal justice setting. And I found that just talking about it makes people more likely to start thinking about why public health matters. Would you like to comment on that?
I agree. I think that one of the things that's so important in our country is that we recognize the importance of public health. America is a country that's very focused on technology. Like we have NICUs and we have, you know, heart bypass and transplants, but public health, on the ground public health, sort of what Bree was talking about, or making sure that we have the community facilities to enable good health. Boy, we need a whole resurgence in that area. So the more that folks, especially clinicians, are emphasizing the importance of public health, not only among ourselves, that's important too, but among the public, it raises awareness that these are issues that affect all of us. And it is important for us to have a village and not just each individual for themselves. There's certainly things that we can do on an individual level, a one-by-one basis, but there's some things that we won't be able to do unless we invest in them as a community. So absolutely, the work that, you know, you're doing to talk to folks and educate them about these issues is critical.
Dr. Thompson, Bree, and Danielle, thank you so much for your presentations. They were very thoughtful. Really appreciated all of the information that was shared. Lots of positive feedback to the three of you coming in through the chat. Really good to see all of you here on the screen with us.